Senior.
Okay, so today's presenter is Dr. Aneena Judge. She is a third-year family medicine resident from CMC Vellore. And the moderator is Dr. Bino Rajamani. He's an assistant professor at the Department of Family Medicine at CMC Vellore. So, Dr. Aneena Judge, you can start presenting. Dr. Aneena, you can start presenting. Hello? Dr. Aneena, we are not able to hear you. Dr. Shweta? You can start presenting, yes. Dr. Aneena, are you able to hear me?
Good evening, everyone.
Okay.
Sorry for the delay in starting because of some technical issues. Today I'm presenting one pediatric case. Presenting Miss Shabina's baby, a 10-month-old girl belonging to a Muslim community from lower socio-economic class.
Hello,
from
Aneena.
Urban,
Excuse me, Aneena. Excuse me, Aneena.
Information is from by the mother and grandmother, and information is labeled. Chief complaints: poor weight gain noticed since 6 months, and history of cough, fever, and fast breathing for 1 week, 5 days back. History of presenting illness: she was born at term by emergency LSAS with a birth weight of 1.9 kilogram, and she was admitted in NICU for almost 40 days and was discharged and was on regular follow-up for 2 months. Mother noticed the child was having poor weight gain by 4 months of age, and by 10 days back, mother noticed child to have fever, which was low grade intermittent in type and which was relieving on taking paracetamol. There was no diurnal variation. Mother also noticed child having wet cough, which was acute in onset, which was not there was no associated aggravating or relieving factors. And mother used saline nasal drops, but the child continued to have cough. It was not associated with any feeding difficulty. Mother also noticed child having fast breathing for the past 3 days. The child with these complaints was taken to a secondary care center where the child was admitted for 1 day. Child was given IV fluids and oxygen with no improvement in symptoms. Child was referred to tertiary care. There, the child has received high flow nasal cannula oxygen for 5 days, along with IV antibiotics and IV fluids. And child was weaned off oxygen by day 5 and was discharged after 1 week. And child had similar complaints at 4 months of age and at 7 months of age. At 4 months of age, child had fever, cough, and fast breathing, for which child was taken to CMC, and there child was admitted in ICU for 1 week, requiring oxygen and IV fluids. And there child was given NG feeds, which was gradually tapered to oral feeds, and child was advised feeds. Again, child had similar episodes at 7 months of age. That time, child was taken to Government Medical College, Vellore. Child was intubated for 1 week and then was on inotrope supports, gradually tapered and weaned off by day 17. And child was started on NG feeds by day 20 and gradually changed to oral feeds and were discharged by day 40. The child, for 1 week back, the child came with complaints of fever, cough, and fast breathing. While the child was taken to CMC, their child was started on HFNC, oxygen, IV fluids, and restarted on NG feeds, and was on discharge, was said to continue NG feeds. And child did not have any history of ear discharge, runny nose, any aspiration of food or foreign body ingestion, which is to rule out any upper respiratory infection. There was no history of effort intolerance, difficulty in feeding, intermittent feeding, any forehead sweating during feeding, or bluish discoloration of peripheries to rule out the congenital cardiac lesions. There was no lethargy, noisy breathing, altered sensorium, or abnormal limb movement to rule out severe pneumonia. There was no history of vomiting, loose stools, or frothy stools to rule out malabsorption. There was no history of polyuria or crying during micturition to rule out urinary tract infection or renal tubular acidosis. Mother also did not notice any difficulty in swallowing or any regurgitation of feeds to rule out GERD. There was no history of scissoring of limbs. There is no history of floppiness or any paucity of limb wounds to rule out cerebral palsy. There was no swelling around eyes, any leg swelling, no abdominal distension to rule out malnutrition like kwashiorkor features, no skin discoloration or hair changes, no nail changes, no yellowish discoloration of sclera. Coming to antenatal history, mother is a known case of seizure disorder since 7 years of age, was on an antiepileptic drug, and towards pregnancy, when pregnancy was confirmed at first trimester, it was changed to levetiracetam clobazam. There was no history of preconception folic acid consumption. First trimester, she conceived spontaneously. Age of conception 23 years. UPT positive diagnosed at home at 2 months, and folic acid was started after booking. In first dose of TT was taken. There was no history of fever, skin rash, any cervical lymphadenopathy. There was no history of UTI, any radiation exposure, or any other drug exposure. In second trimester, she felt quickening at 5th month of age. Second dose of TT was taken. She was started on iron and calcium. There was no history of gestational diabetes mellitus or hypertension during pregnancy. The first and the second trimester scans were said to be normal. Third trimester, she continued perceiving fetal movements, and she continued iron and calcium. Third trimester scan, which was taken at 7th month, was said to have decreased fluid levels and decreased fetal weight. She had one episode of generalized tonic-clonic seizures at 9th month, that is like 37 weeks. Her BP was normal. She was admitted in labor room. She was given medications and she was induced. But in view of failed induction, she was delivered by emergency LSAs on 14th February 2025. Baby cried at birth and birth weight was 1.9 kilogram. Coming to postnatal history, baby was taken to NICU in view of Vellore birth weight and respiratory distress. Baby was admitted in NICU for 40 days. In view of respiratory distress, baby was given oxygen via nasal prongs, and baby was on IV fluids and antibiotics for 3 days. Gradually, NG feeds were started and IV fluids are tapered and stopped. Express breast milk was given through NG feeds. Over 1 week time, baby was started on direct breastfeeds. Baby also had non-hemolytic neonatal hyperbilirubinemia by day 7 of life, for which baby was given phototherapy for 24 hours. And baby slowly started gaining weight. Breastfeeding was established and baby was discharged by 40 days of life. Coming to developmental history, baby gross motor, baby attained partial neck control by 4 months, and baby has not started rolling over. Now attained complete neck control by 9 months of age. Coming to fine motor, baby had bidextrous approach by 4 months, unidextrous approach by 6 months. Baby has not yet attained image of pincer grasp. Coming to social development, baby started recognizing mother by 2 months of age and stranger anxiety by 8 months of age. Language, baby started having cooing by 4 months and says monosyllables by 9 months. So according to the baby's development, baby has a developmental age of 4 to 6 months. Immunization history, she was immunized up to 3.5 months of age according to National Immunization Schedule. Coming to nutritional history, baby was exclusively breastfed up to 5 months of age. And baby was started on bottle feeds with cow's milk in a dilution of 1:1 by 5 months, and breastfeeding was stopped. Soon after this, baby had the first episode of fever, fast breathing, and cough, for which baby was admitted in CMC. And there, baby was advised formula feeds at right concentration, and baby was having baby was on regular follow-up for initial 2 months. Then baby, on the second admission, by 7th month of age, baby was again started on NG feeds, slowly tapered and started on formula feeds, which was again given in wrong dilution. So in the third admission, the current admission of fever, cough, and fast breathing, baby was restarted on NG feeds, and then we are continuing, and plan is to continue the NG feeds. The 24-hour recall diet prior to the admission: diet cow's milk, 150 ml 3 times a day, apple like half. So altogether, the baby received a calories of 330 and protein of 13.5, while the expected calories are 950. So there is a deficit of 620, and protein requirement was 15 mg. There's a deficit of 1.5 grams of protein. Baby, after the NICU admission, was on follow-up in high-risk infant clinic up to 2 months of age, lost to have follow-up since then. The contextual factors here regarding this baby's condition is: mother is having intellectual disability due to seizure disorder. Father is separated and not with the mother. She is unemployed mother and staying with her parents, and is being supported by her family as well as her mother-in-law. All of them belong to lower socioeconomic scale according to modified Kupusamy. And individual factors: mother knows the child is having underweight but does not know why the child recurrently has chest infections and admissions are needed. She is also worried whether the breastfeeding, she stopped breastfeeding thinking that the child will get seizure because of breastfeeding, and this breast milk would cause problem to the baby. And the concern was baby was getting sick recurrently, and the expectation of the mother is to get a healthy, well thriving child. Coming to the examination.
Aneena, we will
To the
stop Aneena
examination,
here.
general examination, baby is
Hello.
alert and comfortable.
Dr. Aneena,
There is pallor, there's no cyanosis, clubbing, icterus, lymphadenopathy, swelling of legs. Vitals, pulse rate is 120 per minute, which was regular, good volume, normal character, and no radio delay or no radiofemoral delay. Respiratory rate 34 per minute. Temperature was 98 Fahrenheit. Saturation is 98 degree in room air. And CRT was less than 3 seconds. Coming to anthropometry, baby's weight was...
Actually,
Dr. Aneena?
One second, sir.
Dr. Aneena, Dr. Bino sir wants to discuss. Dr. Bino sir?
Yeah, Aneena.
Yes,
Now
sir.
we can hear you.
Yes, sir.
Shweta, can you hear me?
Yes, sir.
Yes, sir, we can hear you.
Okay. Now we'll stop here.
Okay, sir.
Basically, we needed some general information about the case presentation. So, what I like to do is, so basically, for our postgraduate examination, even if it is an MD degree or DNB or diploma, whatever. So we will be keeping you one semi-long case for pediatrics. Either it's an basically newborn examination, or it's child with severe malnutrition, child with acute diarrheal disease, or acute reactive exacerbation of reactive airway disease, or whatever. But uh, but for a pediatric case, I think we need to focus mainly four things that you have already mentioned in your presentation. The main I used to discuss in all the forums and all the presentations and all the discussions. One is milestones that you have already explained the milestones. The second thing is anthropometry. I think you will be explaining in your examination, and immunization history and nutrition that you have elaborated. The second thing is before going for any pediatric case history taking, I think we need to carry certain instruments like some small colorful toys or some ball, whatever, to distract the child. We need to get an good, first of all, we need to get a good pediatric history taking textbooks like Sandosh Kumar. I think most of the PGs will have this book called Sandosh Kumar that is very well given. It's a small book. You can, if you're not having one, you can get purchase one. You have to be, I think you have to carry all the other equipments like inch tape, uh, like growth charts. It's very, very important. So without carrying a growth chart, without carrying inch tape, without carrying a torch, without carrying uh, some colorful toys, whatever, you cannot take an actual history because we need to, especially in pediatrics, the milestones, the anthropometry makes much is very, very important. So I think you have to carry all these things. So in this presentation, I think I want all the postgraduates to respond to whatever questions or whatever discussion what we are having today. So is it possible for all the postgraduates to switch on the video and unmute yourself when some questions is asked? That makes more interesting and meaningful, I think. Can all the postgraduates switch on your videos? Because I need to know whoever is watching and whoever is uh, just switched on and doing some other things, because this uh, time of discussion is very, very important for your examination and for your uh, practice. Is it possible for all the postgraduates to switch on? Yeah, sure. Okay. Now, Aneena, go to the your first slide, Aneena. Go to your first slide. Now, I think we can focus our discussion today on malnutrition. Basically, this is a child with a severe acute malnutrition. Now, I think we should be able to get history, collect history about the reasonable history about malnutrition, the evolution of malnutrition, what happens in the womb, what happens after that. And I think we need to discuss something about the contextual issues that makes different from other specialties. So family medicine includes all the histories like individual and contextual issues. So we have to discuss little bit about the contextual factors which actually play a very, very important role in the management of malnutrition. Now, Aneena, what is the importance of what previous slide, first slide? Okay, now can any one of you tell me what is the main role of age in this case? This is a 10-month-old child. The main problem is not gaining weight. So what is the role of what is the importance of age in this case? Can anyone unmute yourself and just tell me? Your answers may be wrong, maybe right. It doesn't matter. What is the importance of age? What is the importance of age uh, in this discussion?
So to know what weight, height we expect in that child, or
Okay,
what development level we expect.
okay, you are partially right.
Sir, also to know how much calorie and protein a child will need
Okay, very
based
good.
on the expected weight,
Okay,
based on the age.
okay, little more, 75% right, little more.
Um,
Okay, some answer is rule out congenital conditions. Okay, little more. Especially if you are talking about severe acute malnutrition, then why this is very, very important. This months and age and why it is important. So what
Doubling
are
of
the two? Yeah, that is one. So what are the two spectrums of malnutrition? What are the two spectrums?
marasmus and kwashiorkor.
Very good. So one is marasmus and one is kwashiorkor. So which age group the marasmus is more common and which age group the kwashiorkor is common? Marasmus
this
is
will be in a younger age group, like less than almost 1 year. Kwashiorkor
Okay.
will be towards like 3 to 5 year, little bit
So
grown up children,
infant,
sir.
so infants is marasmus, and if it is more than a year till 4 5 years, that is kwashiorkor.
Kwashiorkor.
Okay. Okay. Now that is very. What is marasmus and what is kwashiorkor? That we will discuss when the slides go away. Okay. Now, why the religion and socio-economic status is important? Why
So
religion is important?
certain religion will have certain
More common in those socioeconomic.
dietary restrictions,
Like what? Dietary restrictions like what?
like some people might not consume non-veg. Some people will follow some cultural taboos, like not to
Okay.
start weaning on time.
Okay.
And
Some. Okay. Then.
and
Early
social.
introduction of other honey instead of breast milk colostrum feeding.
Yes. Okay. Who said that? Okay. Some may avoid colostrum. Okay. Then what is called pre-lacteal feeds? Pre-lacteal feeds.
Sugar waters.
Yeah, anything other than breast milk in the first 6 months is called pre-lacteal fields. So some group of population, they prefer to give pre-lacteal fields. Okay. Socioeconomic status.
Socioeconomic status, the awareness, their educational background will determine how much mother, especially mother, knows how to take care of the child, giving feeding, and also whether, especially in this child's case, by the time of 6 months, they had to start weaning. But then mother was giving faulty feeding because of a lack of awareness of how to give the feed. And
So SES status is very important in managing patients or children with malnutrition. Okay, next slide, Aneena. Now, this is your chief complaints, right? Poor weight gain and poor weight gain for the past 6 months, and fever, cough, and fast breathing for the past 10 days. Now, can anyone of you from the audience side tell me what are the main causes of poor weight gain in an infant? What are the 5 main causes of poor weight gain in an infant? You have to think in an family medicine or a family medicine specialist point of view, not purely pediatric point of view. You have to think in multifactorial reasons. What are the main?
Poor
What did you say?
feeding,
What did you say, Dr. Mithila?
poor feeding patterns,
Okay.
inadequate feeding.
Inadequate feeding. Okay. That is because of what? Inadequate feeding.
Inadequate awareness among the mother itself can lead to inadequate feeding in feed.
Okay. Inadequate feeding. That is one.
Low socioeconomic status.
Okay, low SES. That leads to poor weight gain. So can you think from something happened in the fetal side, fetal point of view?
IUGR baby.
Okay, IUGR secondary to what? IUGR is a right answer, but secondary to what?
Secondary to
poor
IUGR.
maternal weight gain.
uteroplacental insufficiency.
What insufficiency?
Uteroplacental insufficiency.
Yes, excellent. So uteroplacental insufficiency happens in severe PAH, preeclampsia, diabetes, gestational diabetes mellitus. Okay, so these factors, IUGR, that is one of the factors for poor weight gain. Next, what are other factors?
Low birth weight babies.
Anything related to something related to maternal conditions in the mother?
Pregnancy induced hypertension.
Yeah,
Preeclampsia.
that's everything related to uteroplacental insufficiency.
Even common things like anemia, low socioeconomic status causing poor weight gain in pregnancy.
Yeah, anemia is very, very common, no? Some in low SES. So anemia is one. Intrauterine growth restriction secondary to PAH or secondary to GDM or the other intrauterine infections. Anything else?
Infections during pregnancy.
Pregnancy. Okay. Next, poor weight gain. What are the other main components in this aspect? Harish, you can unmute. Poor weight gain.
Multigravida mother.
Okay, multigravida mother, excellent answer, because the mother will be focusing on one pregnancy or one child or other children, but one child will be taken care of well and the other will be uh, like other will be neglected. So neglected child can have some poor weight gain secondary to those factors. Next.
Gastrointestinal abnormalities.
Okay, now we are in the neonatal period now. Now we crossed the fetal components and now we are in the neonatal period. Now, what are the neonatal components or neonatal problems?
Tracheoesophageal fistula.
Okay, okay. Next, those are structural abnormalities. Any other problems?
Colorectal sepsis, any infection.
Okay. So the first thing is, as we discussed SES, so poverty, the child will be normal, but because of lack of food, the child can have decreased or a poor weight gain. The next problem is any structural abnormalities like any cleft lip, cleft palate, or some facial vessel, all those things, structural components. The next thing is the food is present, no structural abnormalities, but there is increased demand. Increased demand. Tell me two conditions where there will be increased demand of food.
Gestational diabetes mellitus in
Here,
mother,
thyrotoxicosis. All
thyrotoxicosis.
those things are increased demand. Okay, so increased metabolic rate happens in cardiac conditions, congenital heart diseases. The child will be having food, but there won't be enough weight gain because of increased metabolic rate. Okay. Next, the third thing is something related to the lower GA or gastrointestinal tract. Their child is some children they may have persistent loose stools secondary to some fat malabsorption, protein malabsorption. Okay, loose stools, continuous loose stool. The child will be getting food, but it's absorbed, but the problem is in the lower GA. So having loose stool. So these are some of the components we have to think of when a child is having poor weight gain. Okay, next slide.
Lactose intolerance.
Okay, next, can you explain, Aneena, what is this?
So this is the history of the presenting illness. This baby was born at term with a birth weight of 1.94 kilograms, and in view of low birth weight and at birth, baby had some breathing difficulty, so the baby was taken to NICU. So baby was admitted there for 40 days. Baby required IV fluids, oxygen, and oxygen was tapered over by 1 week, and IV fluids also were tapered by 1 week, and baby was slowly started on NG feeds, and that was like express breast milk. Over by second week, baby started direct breastfeeds. Baby, since the baby started gaining weight, baby was discharged by day 40 and was on high-risk infant clinic follow-up for 2 months of age. Then baby
Okay.
lost her follow-up. Baby continued to have direct breastfeeds, and then by 4th month, baby started having. Baby had the first episode of fever, cough, and breathlessness at 4th month. That time, baby was taken to CMC. That time, baby was admitted in ICU, requiring oxygen and IV fluids. And that time, baby started in view of poor weight. Baby was given on NG feeds and gradually started on oral feeds. And then in that background, mother had almost by 4 to 5 months, mother had stopped breastfeeding for the baby. So mother was giving like cow's milk in wrong dilution, like 1:1 dilution. So that time from the hospital, mother was taught correct dilution of feeds and was sent home. But again, mother lost her follow-up. And by again 7th month, baby had similar complaints of fever, cough, and fast breathing. That time, baby was taken to Government Medical College, Vellore. That time, baby was in septic shock. That time, baby was admitted intubated and was extubated by day 17. And there also, baby was started on NG feeds, slowly changed to oral feeds, like oral feeds. And by again this 10th month of age, this is the third episode, the child coming with fever, cough, and breathlessness.
Okay, Anna. So I think you have explained it in a sequential way. Now, I want you to think what are the main complications we expect in a low birth weight child or a small for gestational child or an IUGR child. Now, tell me what is the difference between low birth weight what do you mean by low birth weight? What do you mean by small for gestational age? And what do you mean by IUGR, intrauterine
Low birth
growth
weight
restriction?
less than 2.5 kg due at birth.
Okay. From 2.5 to
2 to 2.5 kilograms, sir.
2.5.
now, then, okay, you tell me what is low birth weight, what is very low birth weight, what is extremely low birth weight, and what is incredibly low birth weight.
Low birth weight less than 2.5 kg. Very low birth weight means less than 1.5 kg. And extremely
Okay.
low birth weight less than 1 kg.
Okay. Oh, incredibly low birth weight. One more there, no? Fourth one. Less than 800 grams.
Less than 800 grams.
800 grams. Okay. Now tell me, I think Dr. Jaya is answering. So what are the main problems you will anticipate in a child with low birth weight?
More prone for infections and
Okay.
pneumonia and diarrhea. And
What type of infections in the first few days of life? What type of infections is that?
respiratory tract infections, pneumonia.
Okay. What is the term called? What is the term called in the preterm or an low birth weight child developing infection in the first 3 days or the first 72 hours of life?
Early onset
Early
sepsis.
sepsis. Early sepsis.
Early onset neonatal sepsis. Okay. Now, what do you mean by small for gestational age, and what do you mean by intrauterine growth restriction? Both are
In
different.
the small for gestational age, less than third centile.
Both are less than third centile. Both are less than third centile only. But some major differences there between these two.
In IUGR, early onset symmetric IUGR and asymmetric IUGR, sir.
Okay.
In symmetric IUGR usually fall in the first trimester itself, where their brain growth is also restricted due to the chromosomal anomalies.
Okay, both
Due
the
to
upper
TARS
half and
infection.
both the limbs, the trunks, all these are affected in symmetrical IUGR, but in
Symmetric
asymmetric,
IUGR.
yeah.
Brain is paired in asymmetric IUGR, usually occurs in the late trimesters of pregnancy.
Okay, what we're telling is the difference between asymmetric and symmetric, but what is IUG? What is the difference between IUGR and small for gestational age? Both are less than third centile.
According to the gestational age, the child has, the neonate has not attained the.
Okay, it is a statistical value we are taking at one point of time, but IUGR restriction is not the one point of time. We are sequentially monitoring the growth of the baby, and we are finding that this baby is not reaching that expected potential, right?
Okay,
But
sir.
SGA is the one point cutoff. We are taking that baby and we are labeling as SGA, but it's like a statistical value. But this is a ongoing value. We are tracking the baby for some months and we are labeling as IUGR. Okay.
Okay, sir.
What are the other complications you will expect? When you said is sepsis, one is any other complications in a low birth weight child?
Respiratory distress.
Yeah, infections. You leave the infections.
Jaundice are getting hypothermia.
Okay, hypothermia is one answer. Very good.
There
Next.
stands for hyperglycemia because of poor reserve.
Okay.
Jaundice.
Okay, hyperbilirubinemia.
Periventricular hemorrhage and hypothermia, electrolyte imbalance.
Okay, electrolyte imbalance. Okay. So you have
Hypothermia.
to. Okay, excellent. So I am getting answer from only 3-4 postgraduates. I want everyone to switch on their mic and switch on their videos and answer. Okay. So Aneena, did the child had any problems like hypoglycemia, hypothermia, or any hyperbilirubinemia?
So according to the mother, child did not have any symptoms of hypoglycemia while the baby was admitted in NICU. But child had hyperbilirubinemia by day 7 of life. That time, baby was under phototherapy for 1 day.
Okay. Now, can you tell me? Can anyone of you unmute and tell me what is the definition of hypoglycemia in a baby, and what is the definition for hypothermia in a baby? We'll talk about hypoglycemia and hypothermia. It's very, very important when you are managing a newborn baby.
ഒന്നും പറയല്ലേ ഫുഡ് കഴിച്ച് കഴിഞ്ഞാൽ ഒരു 20 minutes TV വെച്ചു.
Who wants to answer hypoglycemia and hypothermia?
Less than 45.
Okay.
Plasma glucose of 45 milligram per deciliter sugars. Less than 45 means hypoglycemia.
Okay. How much glucose will give? How much ml of how much percent dextrose you will give?
2 ml per
10%
kg, 10% dextrose.
Okay, 2 ml per kg. In children, in a little older children, you will give?
5 ml per kg.
Okay, 5 ml per kg of
10%
10%.
dextrose, sir.
Okay, now what is hypothermia and how will you manage? And what is cold stress? What is mild hypothermia? What is moderate and what is severe hypothermia? And each of these conditions, what is your plan of management?
Hypothermia is less than 36.5 degree Celsius.
Okay, now 36 to 36.5 is called, what is that? Something called? That's called cold stress. Okay, now what is mild hypothermia? What is moderate? And what is severe hypothermia? And tell me the management of these three. Because a child comes with, or a baby comes with hypothermia, we need to act very fast. I think in our previous discussion, I have mentioned about the metabolic triangle, right? So if a child develops hypothermia, the child can automatically go into hypoglycemia. And if the child has both child can eventually go into hypoxia. Very, very important in managing children, managing newborns. Okay, now, what is mild, moderate, and severe hypothermia?
Mild cold stress means less than between 36 to 36.4 degrees and
Okay. Mild is
35 to 36.
okay. Moderate
32 to 35.5.
okay. Less than 32 is what?
Less than 32 severe
Okay.
hypothermia.
Now you tell me what is your management plan of management for mild hypothermia?
Kangaroo mother care, skin to
Okay.
skin contact, like.
Very good. Very good. What else you can do?
Skin to skin, Gangaru mother care.
Okay. Moderate hypothermia.
Warmer,
Excellent.
humidified oxygen கொடுக்கணும்.
Warmer care. Then you will anticipate sepsis in this kind of babies in moderate to severe hypothermia, and you will take cultures and you will start empirical antibiotics to prevent the neonatal sepsis. Okay. Now, Aneena, can you go to the antenatal history? Okay. Tell me some, now what is, tell me some few anti-epileptic drugs which is teratogenic.
Phenytoin.
Sodium alprate.
Sodium alprate.
Carbamazepine.
Okay.
Carbamazepines.
Okay. Tell me the drugs which, what septal defects or what defects it can create.
Phenytoin, neural tube defects.
Phenytoin causes neural tube defect, no.
Valproate causes neural tube defects.
Phenytoin, what is the problem with phenytoin?
Hydantoin syndrome.
Okay. Fetal Hydantoin syndrome. What are the main, tell me what is fetal Hydantoin syndrome? Answer is right, but we need to know the components there.
Limb hypoplasia.
Okay. What is warfarin? Embryopathy. Warfarin induced embryopathy.
Warfarin
Nasal hypoplasia.
Hypoplasia. Okay.
So there will be Epstein's anomaly.
Lithium causes Epstein's anomaly.
Okay. Now, what is the role of folic acid in pregnancy?
It prevents the
neural tube defects.
Okay. Now, what time you will start folic acid?
Preconceptionally before 3 months of pregnancy.
Preconceptional. So no, this lady, mother did not receive any preconceptional folic acid.
Yes.
Right, Aneena?
Yes, sir. She did not receive.
Okay. Now, what is the current recommendation? How many antenatal visits are recommended by WHO and how many recommended by our Indian government?
8.
Minimum 4.
Minimum of 4.
Minimum 4.
Minimum of 4 visits.
11.
Okay.
Max. 11
Tell me
13.
some 3-4 main crucial things happened in first trimester.
Crucial things.
Yeah,
Uh,
what are the main things which we see in an mother with first trimester?
Hyperemesis.
Okay,
Hyperemesis
hyperemesis.
blood.
Okay, okay.
First trimester.
You bleed.
Urinary tract infection, is it possible?
Okay,
Wait,
we'll screen for the infections then.
Dilutional anemia.
Anemia,
dilution
okay.
in second
Anemia.
trimester.
Anemia is we will screen in the beginning. Okay, next.
Okay, sir.
Failure with rash.
Violent.
Sorry, hypothyroidism. We look for thyroid disorders. We look for anything else.
Overt diabetes
Things
mellitus.
control.
Okay,
Radiation
Serology.
exposures,
okay.
anything.
Viral
We will.
markers.
Viral markers.
Okay,
Serology.
we will do some antenatal scans like dating scans to confirm the
Dating
pregnancy.
scan.
Okay, second trimester. What is very important? Second trimester.
Anomaly scan.
Ah,
BP. OGTT.
okay.
Placenta.
We'll.
USB.
Uh-huh.
Placenta.
Tetanus injections. Okay, quickening is very important. No, in second trimester.
Yes, sir.
Yes, sir. You can.
Yes, sir.
Quickening
Gestational
and
hypertension.
tension, and we'll screen for.
Anomaly scan.
Okay, third trimester.
Growth of the child.
Growth
We'll see the.
scan. TT dose, second dose.
Hmm. Anything else?
Growth scan.
Growth scan.
Oligohydramnios and polyhydramnios.
And we need to know whether the baby is perceiving the fetal movements normally as in the second trimester or not. Because
Yes, sir.
some babies can perceive the fetal movements more than the second trimester. Some babies can perceive, mothers can perceive less. So
Okay.
if it is more than expected than the previous pregnancy or than in the second trimester, then sometimes intrauterine seizures can be present if the fetal movements are more, when the mother is perceiving fetal movements more. Okay, now, okay, then coming to what about the contextual history, Aneena?
Sir,
Oh.
this mother, she is unemployed, and
Hmm.
she was like 10th grade passed. And since 7 years of age, she had seizure disorder, for which she was on anti-epileptic medication. And because of that seizure disorder, she has mild intellectual disability. And she got married, but her husband is not staying with her now. So currently, she is staying with her parents and her brother, and her expenses are being taken care by her brother and her mother-in-law. And okay, sir.
So for all the postgraduates, what is family echo map and what is family Apgar? What is family echo map? Family echo map and family Apgar. Have you heard of these terminologies? Family Apgar and family echo map.
Sir.
Very, very important in family medicine's practice. You have to go back and read about echo map, ECOMAP. You can Google and read today echo map and Apgar. So this family Apgar tells us the family is functional or dysfunctional. A for adaptability, P for partnership, G for growth, and two more. So there are 5 components in this Apgar scoring. So basically, this for a child, we will take the index patient or index member as a primary caregiver. So the primary caregiver, for example, A stands for adaptability. So the question here is the mother or the primary caregiver or the patient, when the patient is in distress, where this patient gets some support. Is the mother or a primary caregiver is getting support from the family members, or for the growth of the family member or the growth of the patient or the growth of the primary caregiver. Now, what support system the family members are supporting the patient in their growth or not? So there, like this, some 5 components are there. So this score tells us this family is functional or dysfunctional. If the family is functional, then I think the etiology or a reason for this malnutrition is not because of the contextual or a family related issues. If the family is highly dysfunctional or dysfunctional, then I think we have to make a plan for family conference. So what we will do, we have to call the family parents, call the grandparents and the close relatives, and we have to fix an appointment with them, and we have to sit with them. What are the problems happening in the family? Anything, any family issues are influencing this baby's weight gain. So please read about his Apgar scoring. This is 0 to 3, 3 to 7, and 7 to 10 is the scoring. Any score more than 7 is highly functional family. Anything less than 3 is highly dysfunctional family. And echo map. Echo map is also another thing to see how many support systems this family receives from the surroundings and the very close family members. Anina, what is Apgar for it? Put the Apgar for this one. Family Apgar.
Sir, it will be more than 7 because her parents are supporting her. They know her condition, and
But you said the husband is separated from the family, is abandoned the family.
but sir, her mother-in-law is supporting her like financially. So other than the husband, her mother-in-law is like in good connection with her, and her parents and her brother is also supporting her. Plus, they are aware of her intellectual disability part, and they are also aware about the baby's condition. So they are willing to take care of both mother and baby for the well-being of both of them.
So you feel that the family is functional,
Yes, sir.
not dysfunctional.
Yes, sir.
Okay, okay. Next slide, Nina. Can you summarize the history alone? To tell me the whole history means what are the things you found out some lagging or some gap in the like contextual or individual history, and you come up with some differential diagnosis. Which system? What is the main problem? What are the factors influencing? So this X, Y, Z is because of due to deficiency of ABC. You tell me like some 3 differential diagnoses.
So this is a 10-month-old girl baby born at term and low birth weight of 1.9 kilogram with poor weight gain not since 6 months of age with three episodes of with past history of 2 admissions of fever, cough, and breathlessness, and currently admitted with the 3rd episode of fever, cough, and breathlessness. And in the past 3 admissions, child was found to have poor weight gain. The baby was otherwise, the baby also has some developmental delay and protein energy malnutrition. And contextual wise, the mother is only mother is being taking care of the baby, and she has intellectual disability and she is seizure disorder and medication. So, so I would like to think in terms of mainly in terms of like dietary deficiency, then there can be chance for recurrent pneumonia for this baby, or like tuberculosis because it's like the 3rd admission with the same similar conditions of fever, cough, and breathing difficulty. And there can be like cardiovascular component also to it, sir.
Why do you say it's a cardiovascular? Anything, any suggestive of what are the symptoms of cardiovascular? What symptom or sign?
Like forehead sweating, like intermittent feeding, taking rest in between taking feeds.
Is there any history suggestive of cardiovascular disease like congenital asymptomatic heart diseases like that? Something, anything like that? Forehead sweating, interrupted feeding.
According to the history, there's nothing like that, sir. But in view of I can consider like GRD also, sir, like because there can be chance of this regurgitation of feeds and in minimal quantity it might not be quantified by the mother, like per se visible like oral or nasal regurgitation, but can cause like aspiration and cause fever, cough, and pneumonia as well.
Okay. Okay. Now, from the audience, can any one of you unmute and tell me what is your main objective or what are the components of clinical examination in children with malnutrition? Now, we are focusing this presentation on malnutrition. Now, before going to any system examination or any case discussion or any examination, systematic or systemic examination, we need to have something in our mind. Okay, I will look these kind of findings in this patient. For example, if it is a severely malnourished child, there are some 4 or 5 main things not to be missed. Let's say take an adult patient with an breathlessness on exertion, orthopnea and PND. So my focus of examination and my objective for this patient is whether he is anemic or not, he's tachypneic or not, whether he has got an elevated JVP or not, what about his blood pressure, what about his heart sounds, is he there in a crepitation, what about his pulse rate, is it regular or irregular? That is my objective for the examination for the adult patient. Is there a pedal edema? Is there an ascites? Is there a tender hepatomegaly to say it's a right heart failure? No. Yeah. Now, similarly, in a child with malnutrition, now what are our objectives? Can any one of you turn on your videos and no, I think the some registrar, some postgraduates are not talking, so I want everyone to get involved here. You can.
Sir,
Now, who
Mean
wants
and
to unmute? You
circumference.
have to unmute and you have to turn on your videos and answer.
Sir, anthropometry.
Who is answering? Harish or?
No.
Okay, anthropometry.
Like weight for height
Head
and
and circumference.
Okay, head circumference, very good. So can you like go in order because this is little erratic. Can you go in order?
So, sir, first we are due to the general examination, sir.
Very good. First is general examination. So appearance is very important. So we'll focus on the components first. Okay, first is general examination. We'll discuss what are the things in general examination little later. So one is general examination. Next is
Vital, sir.
very good. So general examination, vital sign. If it's a sick child, then we'll directly go into the vital signs and general examination. If it is a normal or a non-sick child, stable child, we'll do the general examination first and vital. Second, third one.
Anthropometry.
Okay, anthropometry. Next one.
nutritional.
That is head to foot examination, right? So head to foot examination. Next, what is?
Systemic.
Systemic examination, correct. So, Dr. Jamshir, can you tell me what are the things you will see in general examination?
So in the general examination, we have to see whether the child is active or irritable.
Very good. The child's activity, okay.
Then what is the posture of child?
Okay, very good. So what impression you'll get looking at the posture of the child?
Sir,
Tell
we
me
can
two
see.
postures.
Sir, we can see some. We can get some idea about the motor milestones.
Okay, very good. So in a floppy child, what is a position of the or the attitude of the child in a floppy child?
Extension of the
extension. Very good. Who answered this? Extension of the limbs. Okay, next. General examination. What are the things you will see?
the cyanosis.
Taylor cyanosis.
Okay, cyanosis.
Pallor you can see.
Okay.
In edema.
So is there any lymph node enlargement anywhere?
Okay.
It can give to chronic.
Okay. Pale edema, icterus, pallor, icterus, cyanosis. Okay. The second thing is vital signs. Now you tell me for a 1-year child, what is a normal pulse rate? What is a normal blood pressure, systolic blood pressure? What is a normal respiratory rate? And what are the things? Major 5 things, no? Heart rate, respiratory rate, BP, saturation, and temperature. So, what is a normal respiratory rate for an 1-year-old child? We'll start with the newborn. What is a normal respiratory rate for a newborn?
Less than 60s, 50 to 60s.
Okay. Till newborns means till which month?
Till 28 days, 1 month.
That is neonatal period. Okay. Now till this 60 cutoff, till which month is this 60 cutoff?
2 months.
2 months. Okay. Next till 1 year, 2 months to 1 year.
50s.
Less than 50 is normal.
Less than 50.
50 and above is tachypnea. Okay. Then 1 to 5 years.
Less than 40 is normal.
Okay, so this child is 10 months, right, Aneena?
Yes,
10
sir.
months.
Yes, sir.
So the expected respiratory rate for this child is around 50.
50.
Now, what is the respiratory rate, Aneena, for this child?
This baby's respirator is 34, sir.
34. So the baby is not tachypneic. Baby is comfortable. What is the normal heart rate for this child? For a child? You tell me the normal heart rate for a newborn, for an infant, for a toddler, and for a older adult. Yeah, children.
Newborn
120.
120 to 160.
Okay, for a newborn. Okay. For an infant, like 6 months to 1 year.
100 to
100 to 120.
110 to 120. Okay. For an older children.
60 to 100.
No, that is for adults.
toddler 1 to 3 years, 90 to 100.
90 to 100, we can go up to 110. Okay. Blood pressure, is there any formula to calculate blood pressure in children?
Percentiles.
You can use a percentile chart. There is a formula for calculating systolic blood pressure.
70.
70?
Yes.
70?
70 plus 2 into age in years.
Very good. Very good. So that is the answer. Okay, you can go back and read. 70 plus
2 into age in years.
Okay, so there is a calculation for systolic blood pressure. So those 5 things. So any examination, you should have some objectives in your mind that I will look for this kind of these parameters in this child. Okay. Now, what about head to foot examination? Who will talk about head to foot examination in a SAM child? I want some other to volunteer for this head to foot.
Sparse hairs.
Who is that?
Harish. Sparse hairs.
Okay. Okay.
Abdomen distension.
No, you will come head to foot. You go sequentially. Hair. What are things you will see? Hair.
Here we have to look for any flaky appearance seen in marasmus.
Who is talking this?
Dr. Purnima here.
No. First is okay. Color, no color of the color and color of the hair. Then texture, brittleness. Okay.
Flag sign will be there.
Flag sign. So flag sign is present in
Kwashiorkar.
Okay, what is the reason for flag sign? Because now you mentioned flag sign. Now, what is the reason why there is alternative colors there? What is the reason for that?
Adequate nutrition, the hair normal color will be there. When the nourishment is not adequately
So there
available,
will be correct. So there will be some days of normal nourishment and some days or months with inadequate calorie and proteins. So there will be mostly protein deficiency in kwashiorkor, right? So that is the reason for flag sign. Okay, next what else you see?
We have to see the eyes, any bite spots.
So very good. So now we are talking about the micronutrient deficiencies or the vitamin A deficiencies. Now tell me the classification for the vitamin deficiencies. Vitamin A deficiency. What is XN? What is X? There are some classification, no?
conjunctival xerosis.
Okay.
Corneal
xerosis.
Corneal xerosis.
Can anyone tell from the beginning? XN, X1.
XN is night blindness.
Okay.
Followed by conjunctival cirrhosis, followed by corneal cirrhosis.
No, conjunctival there are two things. No?
X1B.
Yeah.
Corneal xerosis is X2.
X2.
Then ulceration is X3A.
Ulceration. Okay, so you have to learn about this. Now, what will you do if there are signs of vitamin A deficiencies for a less than 6-month-old child, 1-year-old child, 2-year-old child? How many doses of vitamin A you give, and how many in what intervals you will give? What is the dose of vitamin A for less than 6 months?
50,000 interaction.
50,000 interaction. So how many doses you will give?
12 doses.
Sir,
12
three
doses, no.
doses. Sir,
Three
three
doses
doses.
of day
Three
1
doses,
and
sir.
day 2, day 14.
Okay.
Zero.
Now for a 1-year-old child,
1 lakh
to 1
units.
lakh
1 lakh
units.
units on day 1, day 2, and day 14.
day 1,
1 lakh units, day 2, 1 lakh, and day 14, 1 lakh units.
okay.
0740.
What about the 2-year-old child?
2 lakh
2 lakh
international
units.
2 lakh
On the
international.
same day, 2 lakh units on day 1, 2, and
Oh,
14.
okay.
If
Okay,
we
those
add
those are for vitamin A. What about the other micronutrient deficiencies? What are the other things you'll see?
vitamin D,
Okay, vitamin D. What
B2,
are the things?
oral ulcers,
Rickets.
cheilitis,
brittle
angular
bone,
stomatitis.
That is in
Glossin.
vitamin.
B12.
vitamin
That is what?
B,
B
B2,
complex.
riboflavin.
So I'll give you 3 conditions: one with angular stomatitis, one with bald tongue, and one with the painful tongue. Magenta red, beefy red tongue. Tell me what are the deficiencies?
iron deficiency.
Bald tongue is B12.
Excellent.
Angular stomatitis is B2 deficiency.
Okay. What is then painful lesions, painful ulceration, not ulceration, painful tongue?
B5.
Folate deficiency. Folate deficiency. Okay. So that is, so we talked about A, B, other deficiencies. C, what
Vitamin
are the
C deficiency,
Okay.
scurvy,
C.
gum bleeding,
Okay.
then joint pain,
D and
scarbeculosis,
E. D and E.
D and E, poor growth,
Brittle bones.
dental
Okay.
deformity, dental delays,
dermatitis.
Okay.
Sir,
Then
D, frontal
Frontal boss.
Dermatitis.
frontal bossing, bolus,
frontal boson.
valgum,
rickety rosary,
then
What is
bowel,
genu valgum?
Ricket rosary.
What is genu varum, genu valgum? What is cubitus varus? What is cubitus valgus? What is genu recurvatum?
Genuvarum is bowel.
bowlex is
What is
genuvarum,
okay?
knees,
where
knock
the
Bowel.
distal
knees,
portion of the legs towards the axial skeleton.
Knock knees. What is knock knees? Knock knees is valgum or varus deformity?
Valgum, knock knees are valgum.
Valgus. So inward bowing or a knock knees is valgus deformity. Outward protrusion or a lateral bending is varus deformity. Genu varus. What is recurvatum then? Genu recurvatum.
Hyperextension of the knee.
One
Very
limb
good.
is less one limb.
Extension, hyperextension. Okay. What about E? Vitamin E.
Skin conditions.
Skin, vitamin E.
ecchymosis,
Ecchymosis is not in E.
Towards skin appearance.
Okay. But these kind of things will be seeing only in little older children. Okay. Now this is a 10-month-old child. Okay. Head to food, we talked about micronutrition, nutrient deficiencies. Some about the skin things. So now, what are the grades of marasmus, and how will you look for marasmic features in a 10-month-old child? What are how many grades are there? Grades, or how many wasting? Where will you see wasting? Wasting of muscles, grade 1, grade 2, grade 3, and grade 4. Because in general examination, we'll be looking for any loss of pad of fat over those areas.
Baggy pant appearance.
Okay, now what is grade A? Where will you see the loss of fat? So grade A is axillary region and in inguinal region. Okay, grade B is in thighs. Grade C is in abdomen and chest. There will be loss of this thing. Loss of buccal pad of fat is grade 4. So your objective and main focus is there any loss of fat in these areas, in those areas? Okay. Then this is for a marasmic child. Then for a kwashiorkor child, you will be expecting some. What are the features of kwashiorkor?
Edema.
Edema.
Edema will be there.
Edema.
Broad belly appearance.
Okay. Moon-like faces, some edema over the abdomen, edema over the cheeks, edema over the peripheral lower limbs. Okay. Other things in general, head to foot examination. Okay. Can anyone tell me what are the components of anthropometry? How many components are there in anthropometry?
4.
Okay. Okay. Now tell me one by one.
Weight.
Height.
Height.
No. I think Dr. Dakshayani, Harish, Jamshir, all and Jaya. Only these 4-5 registers are talking. So I want Dr. Subhashini, Roshni, Nevin, Surya Krishnan, all to unmute and answer this. How many components are there in the anthropometry?
We also have Aneena and Aravind and coming.
Okay.
Our ODC residents.
Okay.
Height. Weight.
So you want to find
Height for
who is the
height.
height? No. What is first one? First is
Weight for age.
weight for age. Okay. Now who answered this weight for age?
Jaya, sir.
Okay. I think Jaya, you have to answer little. I will give you chance to answer when nobody is answering. Okay.
Okay,
Weight
sir.
for age. What is a calculation for weight for age?
Doubling of weight.
No. I want a calculation for a separate formula for each age group. Aravind, can you unmute your mic and tell me what is a calculation for weight for age? Weight for age. Weight for age. What is a calculation? How will you calculate the expected weight for an 1-year-old child? What is the formula?
X plus 8 by 2 plus 9 by
8.
X in months.
X in months. So age in months plus 9 by
2.
9 by 2. So that is a expected. So let's say for a 10-month-old child, how will you put this formula? So age in months plus 9. So 19 by 19. Okay. 9.5.
5.
Now, Aneena, what is this absurd weight for this child, Aneena? At the time of admission, not the expected.
At the time of admission, the child's weight was 3.7, but the day when I was examined, it was 4.28.
So we'll keep at 4 as 4.
Okay,
now,
sir.
How will you calculate the percentage now? What percentage the child is now?
Less than minus.
No. I want the percentage.
Percentage is 41%, sir.
So 41%. Now, Dr. Annu or Dr. Archana, you can unmute and answer. How many grades are there in malnutrition according to Indian Academy of Pediatrics, IAP? What is normal grade? What is grade 1? What is grade 2, 3, and 4? Because now Aneena is telling the answer. The expected is 9.5, but the current weight is 4. Now the percentage here is 41%. Now who will unmute? Now Annu is here, Archana, yes, Archana is here, Aravind is here, Arifa Rahman is here. Now what is a normal okay, who will answer? What is normal nutrition according to IAP?
More than 80% is normal.
Normal, okay. Grade 1 malnutrition is according to IAP?
71 to 80%.
Okay, that is grade 1. Grade 2?
61 to
70%.
Okay, grade 4 is?
51 to
60%.
Okay, now this child is in grade 4, right?
Yeah.
Severe malnutrition. So according to this IAP calculation, this child falls into severe malnutrition. Okay. Now, Aravind mentioned about height age. Okay, that is the first component in anthropometry. Second component, what is there in the second thing in the anthropometry?
Height for age.
Height for age, or you want to fine tune for this age group?
Length
Less than
of
2. Okay,
length.
length age,
Length.
length for age. Why? What is the difference between length and height? Why do you want to measure length and not height for an 10-month-old child? What is a reason for that?
When the child starts standing, we'll call it as height.
Yeah, that's fine. Now, why it is important? Is there any measurement variation or difference when the child starts to stand and when we measure the child's length in lying down position? Aneena, is there any difference?
So the length, in length, we'll stretch the length, feet, like full length, legs, and then examine. If for a child, as that doctor have told, if the child cannot stand properly, if we make them stand, the child might, the weight, the length might come as less than the original length of the baby.
So what is a centimeter difference when a child starts to stand and when the same child we will measure the length? What is the difference?
So
Approximately around
0.7 centimeter.
No, what you are telling is the proportion for upper and lower limb. This is not
Difference.
The feet
because
and
of because of lumbar lordosis. There will be 2 centimeter, 1.5 to 2 centimeter measurement variation when the child starts to stand. When we measure the height, and the same child when we make the child to lie down and we measure the length. Okay. Now always mention about length for age in an child less than 2 years of age. Third parameter. Third parameter.
the mid upper arm circumference.
Very good. So what is the age group to calculate mid upper arm circumference?
Usually
0 to 5 years.
And 5 years.
It's
6
always
months
to 5 years.
59 months.
yeah, 6 months to 5 years, but not more than 5 years and not less than 6 years. Some textbook says it's 1 to 5 years. Now tell me about the importance of MUAC. What is the normal MUAC? What is moderate? What is severe?
13.5.
Yeah, more than 13.5 is normal MUAC. How will you measure MUAC? What is the method for measuring the MUAC?
Midpoint from
Identify the bony
Midpoint
portion.
acromion
Midpoint between the
acromion
okay, acromion process till the
olecranon.
olecranon. The
process.
child's arm should be in semi-flexed position, comfortably placed. Then midpoint, you measure the midpoint in a non-stretchable measuring tape. And while measuring, the child's arm should be relaxed, not in the flexed position. It should be in the normal hanging down position. That means when you make the child's arm to be flexed, then automatically the centimeter will increase. So you have to be in a use a non-stretchable inch tape, and the child's hand should be relaxed. Okay, what is moderate malnutrition according to MUSC, and what is severe malnutrition according to MUSC?
Less than 11.5 is severe.
Okay, less than 11.5 is MUS is severe. Okay, ma'am, moderately acute malnutrition is
11.5 less than 12.5.
okay. Now, what is the fourth parameters in anthropometry? I think we have to finish within 15 minutes.
Head circumference.
Head circumference. Now, tell me, can any one of you tell me what is a normal head circumference? Normal. What is a head circumference? What is a 3 month? What is the expected head circumference? 6 months. What is the expected? 9 months and 1 year.
3 months, 39 to 40 centimeters.
No, what is there a separate formula for that?
30 months it will increase by 1.
First 3 months it will increase by 2 centimeters.
No, I think I want answer from the
2 centimeters per month for the first 3 months.
Midula is answering. What is that formula, Dr. Midula?
In the first 3 months, the head circumference increases by 2 centimeters per month.
No, it's 4 centimeters. 2 centimeters per month you are telling. In total?
6 centimeters.
No, in total, in the first 3 months.
6 centimeters.
6 centimeters.
6 centimeters, huh?
Hmm.
Is there any other better answer for this? Any other answer for this?
Rule of 4 plus 3 plus 2 and
Yeah,
1. So first,
who is answering this? Who is answering this?
myself, sir, Manorita.
Okay, Manorita. Okay, what is a 2-month increment technique, Manorita? Can you explain to the group?
So the first 2 months, the head circumference will increase by, we have to add 4 centimeter
No,
to the
can you tell the 2 month increment formula first? Then it's very easy for us to understand.
So the first 2 months we have to add 4 centimeter. Next 2 months we have to add 3 centimeters. Next 2 months 2 centimeters, and the next 2 months 1 centimeter.
So the formula is 4 plus, Arif Rahman, she messaged 4 plus 3 plus 2 plus 1 plus 1 plus 1. So the first 2 months is 4 centimeters. The next consecutive 2 months is 3 centimeters, followed by 2 centimeters. Then 1 plus 1 plus 1 in the consecutive 2 months. Okay. Okay. Now, Aneena, can you tell us the anthropometry of this child?
This child's weight is 4.28, which is like
So,
less.
according to IAP, it's in severe
It is
malnutrition.
severe malnutrition because the expected weight for this age is 9.5 kilograms. The length of this baby is 61.5 centimeter, but the expected is 70 centimeter, which is like 78 percent difference is there. So the child will become less than -3 standard deviation, so it will be severe stunting.
So what other, like IAP classification, is there any separate classification for stunting, Aneena, or any one of you can answer? What other?
Waterlow's classification.
Waterlow's classification. What is normal height and what is grade 1 stunting, grade 2 stunting? Any idea?
More than 95% is normal.
Very good.
90 to 95 is grade 1.
Okay.
Everything it will come like 5 percentage gaps. So 85 to 90, 80 to 85, less than
Now,
80.
according to Waterlow's classification, this child belongs to what grade of?
Grade 2, sir.
Okay, grade 2 of stunting. Okay. What about wasting? Is there any wasting? How will you calculate wasting? Jamshir wants to answer. I think his mic is muted.
Present weight divided by ideal weight for present height into 100.
Who is this? Who is speaking?
Purnima, Dr. Purnima.
Okay, Dr. Purnima, okay, can you explain little more? Okay, because we need all the 45 in this group needs to be very clear in calculating wasting. How will you calculate?
Weight for height as percentage of expected equals present weight divided by ideal weight for the present height into 100.
Can you give me an example? Can you put this? Aneena, you tell the value. She will put the weight for height for us.
The present weight is 4.28.
Purnima, you note down this present weight is 4.8.
4.28, sir.
4.28. We'll keep as 4.3.
Ideal weight is 9.5.
Okay.
Then
length? Length 61 centimeters, Aneena. What is the length?
Okay, length of this baby is 61.5 centimeters, sir.
Expected?
Expected is 70.
Around 70. Now, Purnima, can you calculate and tell us what is the weight for length for this child?
It will be 4.28 divided by the expected weight of this child. That is 9.5 into.
No, that is you are telling is weight for age. No, into 100 is weight for age.
We have to calculate it for the present height. That is for 70 centimeter. No, 61.5 centimeter.
Okay, now what is the percentage of weight for length? Why is it important, Dr. Purnima? Suppose I say no, there is normal weight for age. The height is also normal, but the weight for length or weight for height is reduced.
So as to calculate the degree of wasting
Okay,
percentage
degree
of
of
waste.
wasting. Okay, and degree of nutrition we can able to find out. Is it an acute malnutrition or it's a chronic malnutrition? So what will you see in an chronic malnutrition children? Talk about weight for age, talk about weight for length or height, and talk about weight for height for weight for
Height for
age, height for
Wait
age,
for
and weight
height.
for weight for height. What will
Strength.
happen in chronic malnutrition?
Weight for height will be less.
Weight for height will be less in chronic malnutrition. Very good. Suppose all three in what is acute on chronic malnutrition?
Weight for age will be
What
less.
weight for age will be also less and weight for height will be also less. That is called acute on chronic malnutrition. Okay, now Aneena, can you go to the examination findings? Is there anything you want to tell us in the examination findings?
Yes, sir.
Go to the next slide.
Yes, sir. Yes, sir.
So I want you to look into the screen. We have talked little bit about the general examination, physical examination, the head to foot examination without seeing the slides. Now we'll go into the slides and see what some of the things we have discussed and some things she will tell us. Now we will see what she's going to tell us extra. Start.
So from head to foot examination of this baby has sparse hair, but there is no flag appearance or no hypopigmentation of the skin hair. Hypopigmentation of the hair. There is no facial dysmorphisms, and there is no lossy tears, no cleft lip or no cleft palate. And coming to the trunk and abdomen, there is no visible swelling, no visible or any limb deformity, sir. And skin was also normal. There was no scaling, no flaky pain dermatosis or any hypopigmentation.
Okay, next slide.
Coming to the systemic examination, since the child had fever, cough, and fast breathing, I would like to start with respiratory system. So on inspection, there is no usage of accessory muscles. Spine and chest was normal, and skin over the chest is normal. Palpation, tracheus and midline, apex was palpable at the fourth left intercostal space.
Okay, Aneena, any positive findings you want to tell us?
No, sir. Everything was normal. Both percussion hospital, everything was normal, sir.
Okay, next slide.
Even on CVS, other systems
because
like
we are running out of time. We started by 7:45. Shall we finish by 10 minutes? 10-15 minutes. Is that okay for all of you?
Yes, sir.
We will discuss a little bit about the management part and we'll wind up. Okay. Next slide, Aneena.
So other systems are also normal, sir. So the diagnosis of this baby is severe acute malnutrition with microcephaly and global developmental delay, recurrent severe pneumonia. This is a third episode. Possible cause can be because of small for gestational age with history of faulty feeding and consider like upper GI disorder also.
Now this is the diagnosis for a pediatrician. Now we are family medicine specialist. Now I want you to think more about this patient and this child and the family. And you tell me some 10 problems we notice in this family. Apart from this, you tell me 5 problems.
Okay. Single parent, sir.
Very good. So single parent is it a problem? Is it single parent influence the management of this child?
Yes, sir. Especially when we have to give the emotional support.
Okay.
It will be like burden. It will act as a burden for the mother because she will be the whole caretaker of the baby.
Okay.
Then
okay. Single parent is one problem. Okay. Then
unemployment of the mother.
Unemployment. Very good. Unemployment.
And mother's low IQ.
Mother's low IQ. See now 3 problems apart from the index patient's problem. we as a family physician or a family medicine specialist, we identified 3 more extra problems. Okay, what other problems?
Low socioeconomic status, sir.
Low SCS is a problem. Okay. Then, did you mention about the seizure disorder in the mother?
Yes, sir.
Seizure disorder in the mother, is it a
Mother?
problem?
Yes, sir.
Okay, next. Any other
Correct.
problems you notice?
Sir, regarding her ideas about breastfeeding,
Mm-hmm.
Because she was thinking seizure, this child can develop seizure disorder through breastfeeding. That was one reason for her causing stopping of starting weaning of this child. So that
Okay.
part has to be cleared.
Okay. So idea about breastfeeding is not clear, not very clear and evident for the mother, right? So
Yes, sir.
some misconception about the misunderstanding about the breastfeeding practices.
Yes, sir.
Is that a problem?
Like
Yes
in
or no?
future, like
Yes,
yes, this is a problem, especially this child.
Ah.
In view of like low birth weight and having poor weight gain and NICU admission, was supposed to have good follow-up. And by 5th month, the child had first episode of pneumonia. So since then, that faulty feeding has a role in this like malnutrition of this child.
Okay. So see, apart from the pediatrician's point of view or other general physician's point of view, we as a family medicine specialist, see, we have a privilege to go beyond the organic problems. No, so some things we have discussed so far is a non-organic problems or a contextual issues which actually influence the treatment plan in this patient or a child and the family.
Yes,
Okay,
sir.
now something what we want to discuss is, can any one of you tell us about the vaccination status? What about what is vaccination? What is immunization? What are the differences between IAP vaccination schedule? What are the and NIS? Can any one of you tell us quickly, very quickly, within 2 minutes? Because every examiner will be asking you about the immunization. First of all, what is immunization? What is vaccination? Tell me 2 points in immunization and 2 points in vaccination.
Vaccination is immunization.
What is vaccination? What is immunization? No, I want Maria Vimala, I think Ilam, Annath, GRK. I want everybody to participate. Because you are the budding and emerging family physician specialist. So you have to talk in this discussion. Any idea what is immunization? What is vaccination? Dr. Akshita, Dr. Najmat Swaba.
Vaccination is administering vaccines, but immunization is generate antibodies and mount an immunological response
Very
against
good.
it.
Who is answering this?
I am Roshni, sir.
Okay. So, any other major differences between these two? Vaccination and immunization.
Immunization means it's already get protected against a disease either by infection or by vaccination.
Okay. Now, in the other major difference is in certain group of individuals. I will. You have to fill in the blanks. In certain group of population of patients, certain vaccines are not to be administered. Why?
Live vaccine should not be administered
Okay.
in patients. In patients with
immunocompromised status. So certain vaccines are avoided, should be avoided in immunocompromised states because what is the difference between live and killed vaccine? What is the immunogenicity in live and killed vaccine? What is live and what is killed vaccine? You have to read about this, right? Live and killed vaccine. What is the reason why we are not administering? Because in live vaccine, we are actually extracting the viral proteins and we are administering the actual viral particles. But at any point of time, this viral particles can turn into an actual virus kind of picture in an immunocompromised state. So live vaccines are actually contraindicated, but unlike killed vaccines can be safely administered. Now leave that. Now tell me the differences between IAP and National Immunization Schedule. And tell me the vaccination schedule for a 10-month-old child. You have to know about this.
BCG at birth.
Okay, who is talking? Aneena, you want to answer this?
Sir, national immunization schedule will be usually followed by a government hospital, which are mandatory vaccines to be taken for any child.
And it is freely available.
Freely available.
Freely available for all the
children.
Children for all the what diseases?
Vaccine preventable.
Vaccine preventable diseases.
Okay,
not,
sir.
but unlikely in IAP.
Optional vaccines are available.
Again, it's not freely available. It's costly. IAP and some of the optional. Tell me some 3 optional vaccines included in IAP.
Typhoid, hepatitis, varicella.
Meningococcal.
Typhoid. Then what else? Typhoid.
Typhoid, varicella, influenza, hepatitis A.
Okay, one more.
HPV.
Excellent. HPV. Okay. Now, Aneena, tell me in 1 minute, what are the vaccines this child received and what is the vaccination status?
So this child has received vaccination up to 3.5 months of age according to National Immunization Schedule. So the child would have received BCG, OPV, and hepatitis B towards discharge. And then 1.5 months, baby would have received Enteravac and Pneumovac and Rotavirus. That is towards six weeks. Then 10 weeks, Enteravac, and then again 3.5 months, 14 weeks would have received OPV and IPV as well.
IPV and PCV and Pentavac all received.
Yes.
You check the card?
No, sir.
You didn't check. Okay. Now tell me, can anyone of you tell me what vaccine at 6 months, 8 to 9 months, and 1 year?
9 months MMR.
MMR in IAP schedule and MR in NIS or National Immunization Schedule. Okay. Next.
6 months vitamin A.
Vitamin A. Then
Japanese encephalitis vaccine
in
endemic
certain
area.
endemic areas. Okay, right. Now again, Tamil Nadu government has initiated in certain prevalent areas. I think most of they are doing a campaign in the government schools as well. Okay. Okay. Now, how will you manage a SAM child? Tell me 5 important steps. Tell me what are the criteria to admit a SAM child?
Recurrent infection.
Recurrent infections.
Okay. Now, criteria to admit. Okay, infections. Okay.
Electrolyte abnormalities.
Now that we'll come to know after admission.
Failure to thrive.
Criteria for admission.
Hypoglycemia.
Okay. Hypoglycemia we need to admit. Any other?
Hypothermia.
Hypothermic babies will admit. But before that?
Infection.
Infections we said.
The poor feeding.
Poor feeding, lethargy is one indication to start admit the child. Okay, then visible wasting and any edema we will admit. Okay, what are the 10 steps in managing a SAM child? 10 steps. What are 10 steps? Everybody should know this.
Managing hypoglycemia.
What is the first step?
Treating
Treat or
hypoglycemia. Prevent
treat or
hypoglycemia.
hypoglycemia.
Second step is
Hypoglycemia,
treat or prevent
hypothermia.
hypothermia. Third
Ah.
step is treat or prevent dehydration.
Okay, who is speaking? Can you switch on the video? Who is Aravinda?
Yes, sir.
Aravind, can you switch on the video and answer?
Yes.
I know you know the answer, but I just want to confirm that. Okay, hypoglycemia, hypothermia.
For hypoglycemia, hypothermia, dehydration,
infection. Treat or prevent the infection. Okay.
electrolytes correction. Treat or prevent infection. Feeding, sir.
What feeding? What is that feeding called?
Supporting complementary feedings.
No, it's not complementary feeding. No, what is that? What feeding called? You are talking about the components of this feeding. It's called cautious feeding. You have to give the feeding very cautiously. What will happen if you give more calories in these children?
Refeeding syndrome.
Pre-feeding syndrome. So cautious feeding, then catch up growth, then
Sensory stimulation, emotional support.
Yeah, tell me, Harish, what is that?
Sensory stimulation and emotional
Sensory
support.
stimulation. Okay, then arrange for
follow.
Okay. What are the micronutrients you will supplement in this during the admission? Iron supplementation. Anything else you want to supplement?
Vitamin D, vitamin E.
Okay, vitamin E we will give. Then
Zinc.
Zinc. Very good. Zinc we will administer. Then
Folic acid.
Folic acid. Okay, folic acid. Next.
Sir, copper.
Copper, that will give in the zinc sulfate in the zinco bit, but not separately. Magnesium. Highly magnesium. Okay. Now, tell me the criteria, because we have only some 2-3 minutes. I am rushing out. So, tell me, when will you discharge a SAM child?
Adequate feeding.
No, adequate feeding in this. Okay, adequate feeding. The baby should start feeding eagerly. Okay.
Weight gain more than 10%.
How many what weight gain you will expect in these kind of children? How many milligrams per kilogram per day you will expect? Roughly. The main reason for nutritional rehabilitation in these SAM children is we expect these many milligram per kilogram of weight.
7.5 to 15 gram.
Sorry, how much?
7.5 to 15 gram per
Yeah,
kg.
7.5 to 15 milligram, roughly around like 8 to 10 kilograms, milligrams, grams per kilogram per day. We have to weight gain. So if you see any SAM child admitted in the ward gaining this many required grams for 3 consecutive days, then that is one of the parameter to discharge. What is the third parameter component?
Loss of edema.
Loss of edema. Okay, loss of edema. Then
Mid-arm circumference is increasing.
okay, mid-arm circumference increasing, but it won't increase very rapidly. But if we see a child increasing, then okay, then
Tolerating the feeds.
Tolerating the feeds. That is adequate feeding. Tolerated feeds comes in the feeding part. Next one.
Mother is confident.
Mother is confident. The caretaker should be very confident in taking care of the child. In a SAM child at home. Anything else? One more very, very, very vital thing.
Vaccination is
Vaccination. The child should get get vaccinated for all the vaccine preventable disease appropriate for the age. The last question to the registrars. Oh, tell me some few national programs for this malnourished children by our government.
The midday meal program.
Okay, I think you can read about this and you can post in the Tamil Nadu group, in the same group, what are the programs available for these severely acutely malnourished children in the group. I think you can read about this. So I'll just give a brief conclusion about this presentation. So you have to read about the definition of SAM, the triad of SAM, the major differences between marasmus and kwashiorkor. What is the difference between breast milk and the cow's milk? Because we don't have time, so I have skipped this breast milk content and the mother's cow's milk, vaccination, development, anthropometry. You have to be very clear in all the calculations, different classifications, Waterloo classification, EAP classification. Then about the calorie content, how will you calculate what is F75, what is F100? How will you grade the feeds? What is feed intolerance? How many programs are available? Are these all those things we have to read about? Then we need to know whether these families are availing these facilities from our government or not. Some patients and some families are not at all aware about these programs. So we can actually educate the parents about using these facilities in the future. You can talk many family related contextual factors in this discussion. You can talk about the spacing in the mother. You can talk about vaccination. You can talk about educate the mother about especially this mother had some misconception because she's taking the anti-epileptic drugs that can influence that medicine will go through the breast milk. Some amount of misconception. So we are in a place to educate the parents and the educator as a family. So in this way, we will be more proactive and will be very different from other specialties. Not only treating the index person, but we'll be treating the person as well as the whole family. So thank you for your active participation. So you can read about this. You can post. I want all of you to post the national programs associated with in relation with the malnutrition about malnutrition children. Thank you for your participation.
Thank you, everyone. So I thank Dr. Aneena Judge for the well-structured case presentation. Also, Dr. Bino for the insightful guidance and also valuable discussion points. So he highlighted many important practical aspects. So they'll be very useful in our day-to-day clinical practice. Also, I thank the audience for their active participation. So we will also plan another case presentation series in the next month and hoping to meet you all in the same session. Thank you, everyone.
Thank you, ma'am.